Thank you. So thank you very much. It's an honor to have been asked to come this evening, and it's my pleasure to represent the Esophageal Diagnostic Assessment Program this evening. So what do we know about esophageal cancer? Well, we know that this year, 2,000 Canadians will be diagnosed with esophageal cancer. We also know some of the signs and symptoms, such as difficulty swallowing, heartburn, weight loss. We also know some of the risk factors, such as smoking, drinking, and family history. But unfortunately, we also know that many people will be diagnosed in advanced stages, reducing their chances for successful outcomes. And as a result, we know that esophageal cancer has the second lowest 5-year survival at only 13%. So at St. Joe's, we started to ask ourselves some new questions. For example, is there a way we could improve the patient experience? And could this possibly improve outcomes as well? And we knew we couldn't do this alone, that we'd have to partner with our patients, families, primary care, our LHIN, Community Care Access Center, and specialists at St. Joe's and the Juravinski Cancer Center to learn more about esophageal cancer. So when we spoke to our patients, we mapped out their journey to find out what's currently some of the strengths in our system and where are the gaps. And the one clear message we heard was that they had a lot of anxiety and distress when waiting from that first suspicious symptom to actually getting the diagnoses. And we heard that this on average was anywhere around 4 to 6 months. And I recall one of the ladies at this session saying, people would normalize her symptom. She'd be at dinner and say, I'm having trouble swallowing my chicken. And people around the table would say, yeah, I find it a little tough too. But deep down, she knew something was wrong. And it was this waiting until she finally got confirmation that she actually had esophageal cancer was the most distressing for her. So we knew this was something that we wanted to improve. We also knew that we needed a care path so that all patients in our LHIN would get the same standardized care. And we brought together a group of leading experts, including thoracic surgeons, medical oncologists, radiation oncologists, palliative care, head and neck surgeon, gastroenterology, and other healthcare professionals to look at the evidence and to determine what is the best care path for these patients. We also worked closely with primary care. And the one thing we heard from them was, difficulty swallowing is one of the most common patient complaints that we hear. So they really valued a system or a program that could help triage those diagnostic tests for them. And lastly, we looked at successful models like the Lung Diagnostic Assessment Program and St. Joseph's Integrated Comprehensive Care Project, which has a navigator following patients from diagnoses of lung cancer through their surgery and home, which is shown to reduce length of stay, ED visits, and improve satisfaction. And so when we took all of this together, we developed the Esophageal Diagnostic Assessment Program, which was led by a nurse navigator, building on the success of the lung DAP, the same model where the nurse would respond to all referrals within 48 hours, coordinate all the tests, and hopefully reduce the number of times patients were coming in for tests and minimize the need for repeated tests. So what have we learned so far? So we know before patients were waiting several months to get their diagnoses and treatment. And since we've started the esophageal DAP, the average time from referral to completing their tests is about 16 days. And from there, the decision to treat is another 11. So we've made quite a significant reduction in reducing the anxiety and distress people are having from waiting for that confirmation of diagnoses and treatment. We also wanted to look at what percentage of these referrals were actually confirmed malignant cases. So we wanted to make sure we weren't developing a dysphagia clinic, but that we were truly getting those cases that had suspicious cancer symptoms. And so we're pleased to see that just about 50% are confirmed malignancy. And we also measured how many of our referrals were coming from primary care, as we did a lot of outreach with primary care, developing communication materials, a calling card, posters, letters to let them know what kind of symptoms they should be looking for and the number to send their referrals to. So where do we go from here? So is this sustainable and is it transferable? Well, I think we've shown that 2 different models, the Lung Diagnostic Assessment Program and the Integrated Comprehensive Care Project, are definitely models that are transferable to other complex areas such as esophageal cancer. With respect to sustainability, this of course is always a challenge as there's health human resources involved, and so we are looking at ways we can sustain funding for this program so we can support the nurse navigator and clerk. And lastly, improved outcomes. We were fortunate that Dr. Finley, who's here with us today, was able to get a 2-year grant through the Hamilton Academic Health Science Organization. So we've put a robust evaluation in place over the next 2 years where we're planning to measure our outcomes. And our goal really is not only to see over this time, can we continue to improve the patient experience, but can we also save lives? So thank you very much for this honor.